So I would like to introduce today's speaker, Dr. Claudia Gore, who is going to talk to us about atopic diseases in adolescents. Claudia is a pediatric allergy consultant at St. Mary's Hospital, and her expertise is in complex multisystem allergic diseases and in severe eczema. She's one of the authors of the Itchy Sneezy Wheezy website, where professionals, patients and carers can find the resources and videos on management of allergic diseases. And she's very experienced in adolescent medicine and is the lead of the Allergic Adolescent Service at Imperial College. So thank you so much, Claudia, for joining us today, and I will pass the microphone to you.
Okay, well, thank you for that kind introduction, and welcome to today's session. I thought I'll talk to you a bit about allergic teens. Are they terrific, terrifying, or terrifically interesting? And I, in the context of what's going on in the world, decided to focus a little bit on some of the challenges they face, but also we face when we try to help them, rather than going into condition-specific management, which you'll have heard of a lot, which in many ways is not particularly different in this age group to the younger age group. Oops. Okay. So have I got any conflicts of interest? Not particularly, certainly not in terms of inducements. However, I have to declare that I'm a member of the Adolescent and Young Adult Task Force that the European Academy of Allergy and Clinical Immunology has convened a couple of years ago, and there are a number of other people who you may know, and some really very nice publications that came out this year. So why do we have to bother thinking about adolescents? It's obviously always been, in the last few years, a topic that's been quite sexy in many ways. Well, I would say we have to think about them because they're quite common. When you look at EU data, down here you can see the spectrum, the bracket of adolescents and young adults. And what we consider to be the age group of interest would be 11 to 25-year-olds, where we know that they have immense challenges when it comes to managing their healthcare, because there's a lot of change going on in their lives, and they have to be gradually become more independent and self-managing young adults. And what does that mean in terms of numbers? Well, within the EU, there are 43 million awesome young adults and adolescents, which makes up 8.6% of the population. And if you think that prevalence of allergy is in the order of 10 to 30% in the EU, that's a high number. In the United Kingdom, when we look at the number of young adults and adolescents, we end up with a number of 5.8 million in total. And if you then think about how many of them might be allergic, considering the prevalence factors, it's about 500,000 to 1.5 million. Again, quite a high number. So we should be aware that they're out there and that they will come in contact with us. And in pediatrics, the age group that I'm going to focus on is 11 to 18, as really we have a lot of young people in that age group still sitting in our services. So what are their challenges? Well, in this day and age, if you think allergy, you might think eosinophil, or you might think mast cell. But of course, these days, we also have to consider the impact of coronavirus and how that's changed all of our lives. And in some of the aspects of what I'm going to be talking about, I'll use this symbol just to point out some particular challenges that these young people are now facing. But coming back to allergies, when you look at GP database information, you can find that multiple allergic disorders are actually very common in primary care as well as in secondary care settings. But sticking with primary care, about a quarter of people are recorded as having more than one allergic condition. And at the time when this study was done, which is now more than 10 years ago, that was 2.9 million people with multiple allergic conditions. And when we again look at the age bracket that we're interested in, we have the 10 to 14-year-old age bracket here. It's nearly 10% with multiple allergic conditions. And in the 20 to 24-year-old bracket, we've got 6.5%. So quite high numbers that we're facing. So what do I mean when I talk about allergic young people? Well, atopy just tells us somebody's got the presence of allergy antibodies and maybe allergic. But what I'm particularly interested in is the prevalence of food allergies, eczema, allergic gut issues, asthma, rhinitis, conjunctivitis, and of course they may have issues such as chronic spontaneous urticaria, angioedema, drug and latex allergy, and venom allergy. And within the context of our service, we often find that people have multiple allergic conditions, and at the tertiary end that I mainly deal with, they will often have comorbidities including food allergies, severe eczema, asthma, really quite bad hay fever, and they may or may not have some of the other issues. When you think about your own practice in pediatrics, we've done successive surveys on the inpatient wards and found that about 40 to 50% of inpatients at any one time will have some allergic conditions. So there seems to be a higher prevalence that ends up on the wards under typical non-COVID operating circumstances than is out in the community. So, what do we need to think about when we think about looking after adolescents, whether they're allergic or not? Well, all adolescents need to learn the basics of accessing healthcare. All of them should have a healthy lifestyle. They need to know about risks and safe behaviors. And they need to achieve independence and their full potential. And one of the things I'd like you to ask yourself, and we can discuss it further at the end, is how comfortable you are in terms of discussing those types of things with young adults. How comfortable are you about accessing healthcare and advising others to do so? Healthy lifestyle, how often do we address this in the context of any pediatric consultation, but in particular also within allergy consultations? Risks and safe behaviors related to allergy, people usually think about the risks related to food allergies, which are really quite tiny when you think about the risks related to going out in the streets and potentially having, being run over by a car or being a subject to abuse or violence. And how do we encourage people to achieve independence and their full potential, and what do we need to consider? So first thing to consider is, where do we feature in the young person's life? Of course, if you think about the young person here depicted as the blue planet, they have the parents orbiting around them really quite consistently and closely. So lots of interaction there. Then they have their peers who are very important to their life and they spend more and more time with as they become more independent. There is school and education and training under normal circumstances, not within a pandemic. And then they may have other important people in their lives, such as partners. And even though we think we are particularly important, in actual fact, when you think about healthcare professionals, all our lovely multidisciplinary teams, we're actually really rather far out with our orbit. We only orbit into proximity every 3 to 12 months in our service. You'd be lucky if you get into our service every 3 or 6 months. So often young people are on annual follow-up. So what we can realistically achieve in terms of keeping them well and making sure that they can manage their allergic conditions is potentially quite limited. And I would say that's probably the same for most other pediatric specialties, that we're not that much involved in young people's lives. I'm going to start with the challenges for healthcare professionals and then come to the parental challenges before going into the challenges for the young people. So the challenges for healthcare professionals are usually having time to spend with a young person. If you start doing more health education beyond the conditions you need to address, that takes time. At the time of day, young people prefer to have appointments after school, physical space, which should be to their taste and not co-located with screaming toddlers or the elderly, and the location or the co-location with other services. And it's interesting that when you look at how healthcare professionals are trained to look after this age group, regardless of whether or not they're allergic, often we're not aware of the specific needs. We're not specifically trained in adolescent care, let alone adolescent care when it comes to disease-specific management, such as severe asthma or eczema, etc. We're often not comfortable about looking after adolescents because as pediatricians, conversations around relationships and sexual relationships, staying safe, drugs, suicidality, all of those things, whilst we theoretically know we should be doing that, we may not feel very comfortable doing. There are often confidentiality concerns that clinicians have when it comes to speaking to young people or speaking to young people in front of their parents. And managing this triad of the patient, the parent, and the doctor can be quite difficult. And when you then start thinking about having multidisciplinary teams where you may have a nurse in there, a dietitian in there, and if you're lucky, you have an adult clinician in there with you, it gets quite complicated. And in the age of COVID, of course, we've now taken, certainly in our service, more than 90% of our clinics into the remote consultation arena, and that means telemedicine. It's quite interesting that most of the young people I try and reach first thing in the morning are actually not up yet. And I get told by the parent, well, can you phone back after midday because that's when they get up, which is interesting. There are questions around confidentiality, access for the young person to a confidential space, their own phone, and how we communicate with them when often we cannot even see them if it's just a telephone call rather than a video call. So there's some things to consider beyond the usual uncomfortable bits about adolescent care that are even more challenging now. And of course, the youth challenges, as much as I think, you know, the challenges for young adults with allergies are their allergic conditions and their asthma. Actually, when you look at youth challenges worldwide, they're not so much related to their condition-specific management. They're actually very much informed by violence, related injuries, chronic long-term conditions, substance use, teen pregnancy, STDs, including HIV, and mental health disorders. And here we are with our chronic long-term condition, where if they're lucky, they've had access to our service, but the vast majority will be out there. And policymakers have really ignored the needs of young adults completely. Even though there's a lot of lip service being paid to it, there is very little resource invested in that. And physicians continue to report a sense of being ill-prepared and suboptimal in terms of their own self-efficacy in the management of adolescent patients. And if we are not comfortable about how we can help young people manage themselves, it's quite hard to see how we can help them being self-efficient in achieving very much. So let's go to just one aspect of my work that's something that I've actually reflected a lot on since I had a patient who came into my clinic after many years of me looking after her and preparing beautiful management plans and checking that she was okay with them, who at the age of 17 told me, well, actually, sorry, I've got severe dyslexia and I can't read. So how many of you check that your patients can read? Can't see your hands, of course, but
you can put your answers in the chat box.
Yeah, I'd be surprised if it's more than 1 in 10 who routinely check that their patients can read. When I've done this before, it's been, you know, the odd hand in an audience of about 50 to 60. Well, if you look at one of the more recent reports on how Europeans do when it comes to reading, 15-year-olds amongst the girls 13% of 15-year-old girls and 27% of 15-year-old boys have poor reading skills and cannot understand their own school textbooks. So now think back to all the beautiful information leaflets that we have about how to manage your asthma, how to manage your rhinitis, how to manage your eczema. Most of the websites, all text-based. You will find that actually, 10 to 25% of your population may not even be able to read this. Put that together with the attention span, which tends to be getting shorter and shorter amongst young adults and also young and adolescents, it's actually quite hard to get the information to them. And we know from studies that have been done that clinicians poorly assess health literacy in children and young adults with chronic conditions. So if you're looking at your management plan for your asthma, your food allergies, and your eczema, and all you see is some jumble of letters and you don't know what it means, it's going to make it very difficult for you to actually do what you need to do. We've prepared pictorial plans before, but they're quite labor intensive. However, it is important that you check that the young person can understand what you've told them. Even more important now, when we're dealing so much with young people remotely, where you don't have your specialist nurse who can show them how to use that inhaler, you may not have a video link to be able to show them how to use that inhaler or their nose spray. And the website that you refer to, the Itchy Sneezy Wheezy website, currently is down. So where do you send them? How do you give them their management plans? It's quite an important consideration, not just for allergy, but particularly for allergy, because we have so many different types of treatment that require really instruction on how to use them. Inhalers, nasal spray. Most rhinitis treatment fails because people don't know how to use their nasal spray as much as they then don't want to use it because it's not very pleasant. How to put your creams on, where to put your creams on, which cream goes where, and how to do it and step down gradually. So the other things that we're probably not routinely checking is, can your patient speak freely? If you've got them on a telephone line or even on a video call, do you actually know that they're not in the presence of people, who they don't want to talk in front of? Are they alone? Are they in company? Do they feel safe? Where are they? I've had to track down young people who haven't been with their parents, certainly not under a registered address that we had, and have been completely in different places. Do they know how and where to get medication? And do you know how to best contact them rather than their parents, whose number is routinely on certainly our electronic records? And there is no space to indicate for young adults and adolescents, this is the young person's phone and this is the parent phone. In terms of emails, I've found, unsurprisingly, that not all young people have even an email address or use it. So how do you contact them in times of a pandemic? Okay, so that's us trying to interact with the young people. What about the parents' experiences? Well, parents are actually much more aware of the need for letting go and the role change than we give them credit for. Certainly those parents who've been involved in studies. They're also really usually quite keen to encourage self-efficacy. Self-efficacy in terms of creams or nose spray or asthma treatment. They do try to promote that. And when I deal with young adults, especially when I'm at the younger end, sort of 12, 13, I say, well, why don't we start with self-efficacy and you doing your treatment unsupervised or less supervised with a nose spray, with your creams, which are less critical in terms of severe deterioration and hospitalization compared to asthma. I think asthma treatment should probably wait a little bit until you know that they've learned that ability to look after their own treatments. And parents really want to see themselves as a safety net rather than the person who always tells the young person what to do, which leads invariably to a lot of conflict. And within our own cohort, where we have a lot of young people with severe eczema, a 13, 14, 15-year-old does not want to be creamed by their parents anymore. And it's also often not that appropriate if you have the parent creaming a 15-year-old over the whole body. So you have to promote that ability to do some of it themselves. There are plenty of studies around what parents want and how parents see their own role and what their concerns are about the child's future, and also how parents, young people and the siblings want healthcare professionals to be enablers or collaborators rather than just people who tell them what to do. Of course, when you think about the parent who might consider what's happening to their child with food allergies when they go off to university or when they move out of the parental home, I don't know what your university digs or your first shared accommodation looked like, but it wasn't always very clean. And you can see that staying safe with food allergies in a context like this requires some targeted communications. Communications around how to keep your stuff safe and separate and avoid cross-contamination so that you might not have anaphylaxis when somebody's dipped their peanut butter knife into your butter. The added risk factors of alcohol in the context of your allergic conditions and your risk-taking behavior. Over here in the top left corner, what do the allergens do when you have your room organized like this? And how do you share information with your peers? When you look at parent experiences, there are factors that they express regarding their child's autonomy, how developmentally ready they are to take on their treatments, how stable are they emotionally, and how much can they look after themselves. Parents view independence of their allergic young people as a positive event, but also an incremental process, and they very much see themselves as a safety net. And I find that when I have very allergic young people with multiple food allergies, the parents are often very reluctant to let go because they're so frightened of catastrophic consequences, which are in fact very rare. There's a lot of parental anxiety around risk-taking, especially when it comes to allergic conditions and long-term health consequences. And therefore, there's this constant anxiety and conflict that they have between the need to stay involved and the need to let go. Parents find it quite difficult to let go of pediatric services which are quite tailored and cozy and trusted, and they can feel very abandoned and stressed when we just say, well, today your child is 16 and now you're going to go to the adult services. So process is required to prepare both the young person as well as the adolescent, as a parent, to let go. They'd like to have early starts of transitions. So actually, the age of 11, 12 is a good time to start that process and to gradually move through. And joint appointments with adult care would be very much appreciated, but can be difficult to set up because adult services, even under normal operations, are much more pressured in many ways than pediatric outpatient services. And when you think of allergic multi-system conditions, which I mentioned in the beginning, if you've got a young person who has to transition to an allergist for food allergy and to a respiratory physician potentially for severe asthma, and to a dermatologist for severe eczema, it's quite difficult to see how everybody might be able to get into the same room. Mind you, remote consulting and the much increased use of other platforms to consult with patients might make it easier in many ways to get all these clinicians into one room for a young person with complex conditions. So before I keep rattling on, I thought I'll share with you one of the patient stories. And this is Elisha, who put this story together in a digital storytelling workshop for young people with allergic conditions.
When I was 6, I realized people in my class weren't being nice to me. Was it because of my eczema or because I was too quiet? Nearly everyone stayed away from me. Others had milk, I had water. They had jam tarts, I had nothing. I didn't have to worry about anyone calling me names because of my eczema, or being joked about because I was too quiet. I needed to talk more. Because I had a few really good friends who understood. Growing up, hiding my emotions all the time. Outside, I was always a happy child. Inside, I was disturbed. I got piano lessons when I was 7 years old. It helped me forget everything and improved my coordination. One day, some people in my class approached me and asked me whether I had a disease. Did they mean my eczema or my quietness? I said, no, it's just me. When I moved to secondary school, I was around my newly made friends, but I always felt like something was wrong with me. I put on a smile like usual. I felt like I should be like them, talkative and loud, but I wasn't like them. I was shy and quiet. When I was 14 years old, I started self-harming because I hated feeling like I wasn't normal. I went to counseling, which helped me to see that I don't have to slice a sharpener blade into my skin to release my emotions after keeping them in for so long. Earlier this year, I felt suicidal. What was the point of living if I was never going to have the clear skin and the confident personality that most people wanted me to have? I learned that I am normal. Being quiet is okay, and having eczema will not mean that everyone will treat me differently. It's just that some people who don't understand will try and make a joke out of it. I've learned that I just have to ignore them and just be who I am, an introvert girl with eczema, and that's okay. It's more than okay. It's me.
So when I first saw those stories, bearing in mind that this young girl was a patient I knew very well, had in fact been seeing very regularly for clinical reasons on a monthly basis, I was incredibly humbled because even though I felt I'd looked after all her medical conditions, we had a good relationship, I was seeing her by herself, I was giving her all the opportunity to have a chat about things that preoccupied her, I had no idea that she'd felt suicidal, and I had no idea that all this stuff was going on in her life simply because she didn't disclose it. And it brought me back to thinking that in actual fact, it's incredibly difficult to know what's going on, and it's incredibly important that we don't forget just where we sit in our patients' lives, in particular when it comes to adolescents and young adults. We're quite far away from what's going on, and the opportunity to shape what's going on and to help them treat themselves is a precious opportunity, but also quite tricky to sort out. So what are the factors that represent, that affect the way allergic young people, that affect allergic young people? As part of the IACI Adolescent Task Force, we've done quite a big body of work around the challenges adolescents face and what can be done to improve things. And well, some of the things I show here have now been published in a systematic review on those challenges and relate largely to young people with asthma, with some data available for young people with eczema and food allergies. Which is interesting in that a lot of focus is often on asthma, but the other conditions which are very distressing and carry a high psychological morbidity are often neglected. So there, the obvious individual factors such as demographics, socioeconomics, age, gender, culture, and language We know that if you're in a low income setting, you have more pressure on your health. Ethnic minorities often do worse when it comes to outcomes, and that includes allergic outcomes. If you have allergy onset when you're older, that's associated with poorer quality of life. Girls with allergic condition tend to be more anxious, but boys have reported more effect on relationships and being able to initiate relationships. Depending on your cultural background, a lot of the data comes from the States, where we know Hispanic youth are less likely to ask for help. And I'm certain that cultural factors within our inner city London practice also play a big role in terms of health beliefs and how healthcare is accessed. And then there's this question of language. And it's not just the fact that we're often dealing with first, second, third languages that might be spoken in our clinics, but also that a young person's language is different often from our own language. As much as I might flatter myself that I know how to talk to the young people, probably that is not the case. Other fixed factors that we cannot do much about within the setting that we're in is comorbidities, severity of the disease, and what it costs them to look after themselves. We know that there is an additive effect of asthma and allergic rhinitis. There's really no data of the additive effects when you take eczema or food allergy in addition to that, which is surprising considering the large number of young people with multiple allergic comorbidities. We know that suicidality is associated with severe eczema and itch. And we know that people with allergic conditions, be it food allergy, be it asthma, be it eczema, have higher out-of-pocket costs, which can be a big barrier to adherence. And when you get out of, when you leave full-time education, one of the big out-of-pocket costs will be that you have to pay prescription charges. And if you're looking at multiple allergic comorbidities, you might have 5, 6, 7 repeat prescription items. You can see that that can be very expensive very quickly. And then clearly another fixed factor is what's going on in the system in terms of health policy, resources that we have, and external factors such as, for example, the current pandemic. So what can we do anything about? Well, we can make sure that we are trained to look after young people, that we have the knowledge how to communicate with them, and that we can take the time and make the time to build up a partnership and to address some of the more difficult issues. And we know from studies that adolescents, and that includes allergic adolescents, value the exploration of their knowledge in a non-judgmental environment. I'm very open with mine and say, I'd rather you tell me the truth that you managed to take your inhaler 1 out of 10 times that you should be taking it, because then I know what I can do to help you maybe improve that. Whereas if what we get is, which is often the case, I take my inhaler 2 puffs morning, 2 puffs night, every night with the appropriate spacer device, I know they're not telling me the truth, and that makes it quite difficult. We can enlist the social network that they have, in particular the peer support. We know that when young people have good peer support, that facilitates good self-management. And we also know if there is a lack of knowledge in a family, or if there are some significant odd health beliefs that can be obstructive, that can really impact on the young person's health, to the point where they may end up very severely unwell and end up in hospital more than they should do. And bullying is very common. Up to 40–50% of children with allergic conditions have experienced that, and that includes adolescents. We can work with them on their coping skills and coping style, and how they assess risk by having open conversations around risks. And we can do, to some extent, help with psychological issues such as health beliefs, illness perception, symptom perception, how we can help them through that. For example, you're asthmatic who does not recognize anymore that they are symptomatic. But the big point where we have to help is with self-management and which one of the 8 different medications they may be on for the allergic comorbidity they should focus on. So the big thing is here that we focus on self-efficacy in terms of their adherence, prioritizing, trigger avoidance, but not over-avoiding and over-restricting their lives, problem-solving skills and coping skills, and empowering them with the knowledge of what they can do about, you know, how they live with their food allergy. Do they do the shopping? Have they learned any recipes? Mine should not leave my service without having at least one different recipe for every day of the week, so that I know that they can cook for themselves. And when you get those things right, you will end up with improved quality of life, better confidence, better level of symptom control, better mental health, and a better transition quality. We know from a qualitative study that we've done that multi-system disease significantly impacts on the adolescent in terms of their life restrictions, peer group studies, mental well-being. We also know that it equally impacts on the parents who have to live with these conditions as much as a young person when they live together. And both sides are interested in having the best possible, most normal life that they can achieve with bad eczema, bad asthma, and multiple food allergies. I'm not going to go into the HEADS assessment in detail, but within asthma and eczema and allergies, there are some HEADS plus. So at home, of course, it's not just where you live, who you live with, it's also what are your exposures to triggers. Education and employment, future plans are quite important. If you've got multiple food allergies, if you react to inhalant fish exposure, you may not want to be a chef. So where can you go with that? What does your employer need to know? What are you doing? And especially now when it's coronavirus time and many young people with allergies and asthmas seem to have read into the whole situation that they must not leave the flat, must not leave the house at all. Have you experimented with any substances, any friends of yours? What's your, any relationship issues? Are you in a relationship? What's your mental health like? Important topics to cover: how to register with a GP, how to get past a receptionist, how to get your prescription, prepayment prescription certificate. Join the NHS prescription club, because if you've got 5, 6, 7 different repeat prescription items, it's worth your while paying 110, 115 pounds per year to get those for free. There are exemptions for young people who are out of full-time education, who have not got a lot of family income, where you again would qualify for free prescriptions. What do you know about that? Do you know how to signpoint them? And this is the image I've just put in today, is just some of the practical challenges when we say do this, do that, carry this, carry that. I've put a sort of handbag here, which the sort of size is about 25 centimeters in width, and all the things that we might expect people to put in there. I've put this tiny little spacer here because the oldest person I'm aware of who had a pediatric infant spacer was one of my husband's asthma patients, who at the age of 40 came in with one of those. But we say don't take your MDI without a spacer. It doesn't fit in here. Even the blue arrow chamber wouldn't. Carry 2 pens. They just about fit. But then you need to have your other stuff with you. You need to have your tissues with you for the hay fever season. You should have some creams with you. You may want to have some other stuff with you, your phone, your mask, your everything, your sunglasses, and whatever else you carry. And it does not fit. So invariably what happens is people focus on the things that are important to them, and that will not include spacer devices. It often does not include the pens because there's no space to put them. It will include an MDI if you're lucky, so pick a device that they can use without a spacer, not your average MDI. Make sure they know that they don't have to have an antihistamine liquid, but tablets do the job if they can swallow them. And make sure they know that going out without an EpiPen if you've got severe food allergies is a bit like driving a car without a seatbelt, and explain to them why. There are issues around job choices, which I've already alluded to, and in addition to the Ready, Steady, Go program, which you may be aware of, and all the questions that we ask, my little sort of aid memoir is lots of P's: pens, peers, pubs, peer pressure, partners, pots, parents, plans, and prescriptions. And if you get it right, then it goes well. So here's one other story before I wrap up. This is Priya, who again shared her story in a digital storytelling workshop a few years ago.
Eczema girl. My own then best friend gave me that delightful name. Between the name calling and the cruel glares, an angry little girl is standing. My earliest memories include primary school, being bullied every day, whilst horrendous teachers chose to turn a blind eye to the mean acts against other pupils, including me. Eventually, the continual anger building up inside of me was finally released in an explosive push of my best friend to the ground, calling me Eczema girl and crusty. I instantly dashed away, not noticing the damage I have caused, which happened to be a broken wrist. It was always, what's wrong with your skin? Why does it look like that? No one wanted to partner with me in class for like PE. People used to run away from me in school and not touch me as I had the germs. My older brother and I are 3 years apart, and we funnily enough both started developing eczema at the young age of 6 months old. My eczema has mostly been controlled until our trip to India in 2009. My family and I were desperate, wanting my asthma, eczema, allergies, and hay fever to all disappear, so we tried out some local remedies. This, along with the dirty environments and open wounds, led me to come back to London with a serious infection. It was physically and mentally exhausting, trying to hide the discoloured skin to the point where it was scary to look in the mirror at my face in the mornings, as I didn't know what state it would be in. It felt I didn't even look myself or have a normal face anymore, as it always felt tight and dry and cracked. I was immediately admitted into hospital hours after my consultation with Dr. Gore. Here I had wet wrap treatments, as well as a long list of other medicines. This was very full-on and overwhelming, as I had never experienced something so invasive. The wet wraps were very cold and sticky at first, leaving me shivering all night. Now, some years and another admission later, I finally understand what I am doing and what works for me. This was partly because it took time for me to accept the conditions I will probably have forever and the responsibilities I would have to upkeep on a daily basis. I feel I needed the freedom and time to experiment with the different treatments available and feel comfortable to administer the medication myself. In some ways, having the condition I have has made me the person I am today. I have developed thick skin at the expense of emotional scarring, as I feel these experiences have buried deep inside of my memory, making them difficult for me to talk about. For a while, there were periods of depression, anger, and embarrassment, which I personally don't feel will go away anytime soon. I feel my passions, music, singing, and baking, have definitely helped me to overcome some of my anxieties and confidence problems. I am now 17 years old and still have eczema, asthma, and various allergies. However, the difference is I understand how to cope with flare-ups and bullies.
I think Priya expresses the journey very eloquently when it comes to how to grow up with your allergic conditions and what it means. And you can see from the story she tells that she's had to come to terms with the multiple different treatments and how to work it out for herself, what she actually wants. And again, for me, it was a very humbling story to hear how all our attempts to make her feel better actually were a rather invasive experience for her, something that she never disclosed until she told this quite courageous story. So where are we up to then? I would say in summary, with respect to your patients and to your allergic patients, make sure you know the basics of the treatment, which you've heard a lot about in the Allergy Week, but that you get trained that you can deal with a double A, the allergic adolescent, and that you talk to them and that you give them the space to actually express what their thoughts are by themselves as well. Make sure you don't forget the parents. They're an incredibly valuable partner in getting the young person ready to take on their own conditions. And you often need to transition them as well. I find within the food allergic cohort, parental anxiety is incredibly high. They want to let go, but they find it really hard after often 15, 16, 17 years of checking everything, the minutest detail on every food label, to let go of that responsibility and to let the young person take that on. And then with respect to young people, facilitate, collaborate, recognize their challenges beyond the medical bits that you see in front of them, explain transition, start it early, be non-judgmental, and keep things confidential. And with that, I think you'll be able to do a good job, because treating allergic conditions, the basics, which cover 80 to 90% of what your patients need to know, is not rocket science. It's all about understanding why you need to use it and how to use your treatments, and being able to access the treatments, especially in times of COVID. And with that, I'll stop. Thank you.
Thank you, Claudia. There was a very interesting talk, and we can see that you are very passionate about adolescents medicine, and I'm pleased that you've been here today to share with us your experience in the field, because I found I speak to myself, but I believe there are other people in the audience. As a pediatrician, I found myself much more at ease to talk, to deal with children rather than with young people. It's a very scary field, trying to talk to them, try to build a trust relationship with them. We have time, a few minutes for questions from the audience. You can type them in the chat. But in the meanwhile, I'm going to give some time to people to type their questions. I want to ask Claudia a question myself. Especially the videos were very powerful, and especially the first one, and your experience with the first child made me think about how and when do you think is appropriate to refer a child with a clinical condition, a chronic clinical condition, for psychological support, because as you said, we meet them once a year, twice a year for 15 minutes, and we may miss some signals that they may actually need help.
Yeah, well, that's a very good question. Of course, in my ideal world, they would all have access to psychological support every time they come in contact with our services, and beyond that. But I mean, realistically, I think the first step, and that's not just for our patients, but also for ourselves and our colleagues and in life in general, is to say that it's okay to feel bad and to find things difficult, and that it's okay to talk about it, and that it's not something abnormal. If you need to, sorry, I need to just it's not something abnormal to have psychological difficulties and to find it challenging to live with a chronic condition. So that is the first step, because if you don't kind of normalize it to an extent, then you will not be able to start this conversation. And people talk about the heads assessment, where you should be exploring this, that, and the other, but it takes a bit of trust for you to get answers from the person who sits opposite you, or the person who you may not even have opposite in the room to you now, where you don't have the benefit of being able to pick up non-verbal clues. So it's acknowledge that it's hard, acknowledge that it's normal to find this difficult, maybe not every day, but to find it very difficult at times, and acknowledge in particular at the moment that it's even more difficult because we've already, all of us, got our own anxieties anyway about bits and bobs of our lives, and now we've got this big thing on top of that where the information around how that affects people with asthma, how that affects people with multiple allergies, is just not out there and creates even more anxiety. And the simple step of saying it's normal to feel really anxious, and it's normal to, I sometimes, pardon my choice of words, I sometimes say it's normal to feel a bit shit about stuff, because it's some days it stinks, okay? And don't be afraid to acknowledge it in that way.
Okay, thank you. Are there any other questions from the audience? If not, can I just steal 2 more minutes, Claudia, for another questions from myself? So regarding the Ready, Steady, Go and how we should start early to involve young people in their own health and their management. So the Ready, Steady, Go plan says that we should start 11, 12 years of age, but definitely looking at the parents' eyes when I ask them to leave the room to have a private conversation with a 12-year-old girl, they're most of the time very surprised and they're shocked by the question. So I don't know if you have any experience you want to share, or if there is any advice, any suggestion on how to deal with this situation.
Yeah, I mean, and again, I'm not going to make this allergy specific because it's for any walk of life. And I know I didn't quite sort of do my brief here about allergic adolescents, but I thought that the adolescent bit was a bit more important than the allergy bit at this stage. So I encourage all of my patients, regardless of age, to speak for themselves. So whether they're 5, 6, 12 or 16, I want them to speak for themselves. And that obviously has the parent in the room in the beginning. But as they get older, I introduce the concept of, well, we may not do it today. If you want to, you can speak to me by yourself for a couple of minutes so you get used to it. Because the parent knows, and the child, young person knows, that at some point pediatric care finishes and they have to do it themselves. So I start off by saying, at this age, I offer that you can have a chat. We can just chat about anything for a couple of minutes without your parent. If you want that today or not, because they need to say yes to that. Then I often just start with, how's school, how's life, how are your friends. I don't, in fact, talk much about the sort of nitty-gritty of allergy care. And then you document how far you've got, and then really the next time would be when I say to them, especially when they're getting to 14, 15, I expect that I'll see you by yourself for a little while. And that doesn't tend to be a problem. And if both sides, the parent and the young person, understand why we're doing it, which is basically to give the young person the skill, and I say to the parents as well, it's to get you used to letting little Johnny, who's no longer so little, speak for themselves. You have to get used to it. He has to get used to it. Let's start it now. And that works quite well. And I have as little continuity for a lot of the patients as most other people. Some select few are lucky and get to see the same person, i.e. me, all the time. But the majority of young adults I have in haven't seen me before. They may have come from another clinic. And just to share with you my experiences from the last 4 months, it's been remarkable how many parents seem to think it's okay that they speak for their 16-year-old or their 17-year-old or their 18-year-old in a couple of occasions. And I have to say, well, actually, I'd quite like to speak to the patient, and that's not you, you're the parent. Oh, well, they're asleep. Well, go and wake them up. I cannot discuss this all with you. I need to know that they're there, that they're okay. And I want them to engage in this even more so now, because it's so easy to not engage. And one of the big issues we have with young people is that engagement can be tricky. And if we lose them now that it's mostly remote consulting, I think is quite dangerous.
Okay, thank you. There is another question in the chat, but I think you covered it with other practical advice or sharing of your practice, which we can adopt when we have young people in our clinic room.
Yeah. So with respect to any kind of transition, as much as allergy transition, I chat about medication. I obviously want to know that they know what they're on, because if they don't even know the name of their medication, then we have quite a long way to go. Mostly because they've been with us for quite a long time, they actually know their stuff much better than they will let on when the parent is in the room. And the practical thing I do there is then I find out, I say, what happens if you miss a dose, if you forget a dose? And I'm quite open about the fact that 50% of patients don't manage to take 50% of what they need to take. And that's worldwide data. We know people find it really hard to take stuff, including, you know, myself. I have to have ways of reminding myself to take my medication. So we talk about that. And I explore what they would do. So we do a bit of scenario-based stuff. So let's say you haven't got your pen on you and you're out and about and a peanut flies into your mouth and you react. What would you do? I'd use my pen. Well, you didn't take that. You've just told me you don't carry it. Oh, so we talk through that. And that's the same. You can do that with asthma. And as you get used to your little scenarios and talking through those scenarios, I find actually they respond very well to that critical thinking element, where they have to say, okay, if they don't carry their pen, I say, well, what is the first thing you do when you get into a car after you've shut the door? And they sit and they think, I go, well, put my seatbelt on. Well, why do you do that? Well, because I might have an accident. Oh, well, your EpiPen is your food allergy seatbelt, okay? So when you go out, you need to have that with you. How you remember it is something only you can work out. But, you know, you remember to put your seatbelt on, and that's back behind you. It's not like you see it all the time. You just do it because it's a routine. And medication and carrying things with you, same routine. And they don't ever forget to take their mobile, do they? So we talk about it in slightly more informal ways. With respect to personal problems, I think the first thing to establish is that they feel they can trust you, and that if they do say something, that you'll keep it confidential. But the other thing that's often a problem is I think that they perceive that we can't do much about it, which is often true. You know, we don't have a psychologist there. It's even harder now to do anything about it. But I've just allowing, as I said before, allowing a conversation, saying that it's normal to find it difficult, I find works well. It works on the telephone as well.
Okay. Thank you, Claudia. That was very helpful. And
I can see all these little squares with no picture and lots of muted microphones. If anybody
very
wants
invisible audience,
please do. Okay. I know there is no one size fits all here, and as I said, the basics of allergy care are actually pretty straightforward. And with young people, the big thing is to let them learn that it's pretty straightforward. But learning the straightforward isn't always easy. Learning to remember things isn't always easy. You know, people remember to clean their teeth twice a day because that's what they've been doing since they were infants. But of course, they weren't carrying the pen since they were infants.
Okay, thank you. I think for the interest of time, we are running slightly over. We need to close it here. Thank you very much, Claudia, for sharing your experience and your knowledge, and thank you everyone for listening. I put in the chat a link to our allergy learning pack and to our survey monkey, just leave us a feedback to today's session, please. And please allow me to share with you some information about, I think you can see it, about the Imperial College allergy postgraduate allergy courses. So they organize intensive 2-day courses, diploma, certificate, and MSc in allergy. And I have to say, I have a student, an MSc student myself. I'm in my last year, and I found it so much useful to build up my theoretical knowledge in pediatric allergy before I started working in clinical practice. They're very flexible, and it's accessible also for full-time workers, because they work around our timetables. So just to remind you again, the session will be on the YouTube channel of the London School of Pediatric, and please fill up the form, the feedback form, and we'll see you this evening at 6:30 for another session of the Allergy Week. Thank you very much. Thank you, Claudia.